to the support group tonight. Thank you for being here. Thank you for taking time out of your schedule to come and listen. This is a good presentation today. I know there's questions in everybody's mind about complications, right? Something that maybe we don't talk about enough, or some patients feel like they don't have the info they'd like to have about it. And they can certainly happen. If you remember when you came to the seminar, thinking about getting this surgery, we talk a little bit about the possibilities, but we also are very emphatic about letting you know that our complication rates are very low. And so, yes, they are very low, and if you're going to have the surgery, you want to come to a center that does thousands of them, that has really worked out all the kinks and can avoid the complications. But the complication rate is never zero. And thankfully ours is much lower than the national average, but it's not zero. And we do get complications, and we have seen them. And you may know somebody, or you yourself had a complication. And what I tell patients is, yes, our complication rate is not zero, but if you do develop one, number one, we'll know how to diagnose it, we'll pick it up, and we're not going to let you get worse. We're going to know how to fix it, and we're going to help you through it. So we are streaming this on Facebook Live, and if you'd be so kind as to let us know if you're receiving adequate sound. I know we've had some issues in the past with not getting good sound on the Facebook live stream, so if you don't mind, please type in some comments, and if the sound is good, just let us know that. Otherwise, we'll make some adjustments. So far, so good? All right, wonderful. Okay, so I'm going to try to talk for no more than 25 minutes or so, maybe till about 6. This is kind of a general presentation. We're not going to get too far into the details of every single complication. Rather, we're going to cover the main ones. We're going to talk about what is a complication, what's not really a complication, and then we want to leave enough time for the best part of these discussions, and that's the Q&A at the end. And because I want to know what your questions are and what you would like to know more about this topic. So these are the common questions, right, that everybody asks themselves. Will I have complications? Which are the most common? Which are the most serious? I'm sure that when you were thinking about having this surgery, some friend or family member told you, oh no, I know so-and-so, and they died. They never made it out of the hospital. Don't do the surgery or whatnot. Certainly, some of those horror stories are true, unfortunately. If you look at the way the surgeries were done back in the 80s and 90s, and the field has come a long way even in the last decade. And thankfully, there are organizations now that are kind of, I wouldn't call them watchdogs, but they help us improve our quality because they're constantly going over our data, and we turn in our results to them, and they come and they visit the hospital, and we have to meet criteria or we don't get designated as a center of excellence. And then you can't have your surgery here because your insurance is not going to send you to a place that's not a center of excellence. So we are very deliberate and intentional about reducing complications, and most of these complications are preventable if you put the right elements in place. And so thankfully we have a wonderful program here, and as you know, Katie, our coordinator, is in charge of a lot of that, of making sure these protocols are in place, of gathering the data, and we're constantly reviewing what our numbers look like so that we can get better and better. And what causes them? Is it something that the patients do? Is it something that they've done, or did it just happen? And if you do develop a complication, is that going to ruin everything, and then you're not going to lose weight, which is the reason why you had the surgery, to get healthier and lose weight. And so how do you treat them if they do happen? That's some of the things we're going to talk about. So there definitely is a difference between unpleasant, undesirable side effects of weight loss surgery and true complications, okay? And we'll talk a little bit about what the difference between those. In general, I would say that a complication is something that is going to require care, like professional medical care by your team, where you will have to come and you may need tests, blood tests, imaging studies. You will need some kind of treatment for this complication. This isn't something that we reassure you over the phone, hey, don't worry, just try a little bit of this, or it'll get better. those are some kind of unpleasant side effects, a little bit bumps in the road, and then your body kind of heals itself and you get through it. Not a complication. Complication in general, there has to be a plan in place. We have to figure out what happened, and sometimes it'll require hospitalization, sometimes even surgery or other procedures. Sometimes it's something that can just be treated with medications or maybe just an IV bag, but that in general is kind of the definition. And some of these can be acute. They can happen quickly and in a few days, just totally change your plans because now you need emergency surgery. Or they can be happening over several months and slowly be getting worse. Some of them are just treated medically and some are surgical. And some are actually specific to the type of surgery. In other words, some complications typically only happen with the gastric bypass, and some are very unique to the sleeve. And so that's kind of what we'll talk about. I won't really talk about band complications here because that's kind of a whole nother topic. But we certainly have seen complications from the band and know how to take care of those. I don't talk about it because we just don't put them in anymore. And so generally when somebody comes in with a band that is not working or that slip, it's pretty easy to diagnose that it's not working. And then now our default is, let's take this band out if it's not working. And if the patient would like to and they qualify, they can actually go on to one of the revisional procedures. So this list here is what I would call not really a complication. These are things that can happen after weight loss surgery. Probably they're undesirable, some more than others, but these will generally get better with time or with a plan. Of course, if you have gallstones, that may require surgery, but gallbladder issues are not a complication of weight loss surgery. It's just that gallbladders tend to give more problems after rapid weight loss. So we know that, but I wouldn't call it necessarily a complication. But certainly 8% of patients after weight loss surgery will need their gallbladder out, compared to 4% in the general population. So dumping syndrome is another one. And we won't talk too much about it, but dumping syndrome is 100% preventable based on what you eat or don't eat. Avoiding high calorie, high carb foods will prevent dumping syndrome, but it's one of those unpleasant side effects that can happen. Sometimes the mild dehydrations, if you get a little bit nauseous, if you just get behind on your fluids and get weak. Now, I will say that constant repetitive dehydration is usually a sign of something else going on. There's a reason why that patient is not getting in the fluids or nutrients that they need to. Maybe it's an ulcer, maybe it's a stricture. So if somebody's coming in repeatedly to get IV fluids, we look into that to see if there's not something underlying. And then some patients struggle with pain a little bit more. That left-sided pain, some people it goes away in a couple days, and I've seen patients come in 3 weeks after surgery and they're still hurting, and they need to get some muscle relaxers or something like that. So that can happen, but not really a complication. Constipation is almost expected, and I'm sure you've been there. Or you are there, but there's things that can be done to address that. Temporary hair loss, the excess skin, or delayed weight regain, those are things that can happen. But this is the list of true complications that are going to require medical care, okay? So ulcers, strictures, intestinal obstruction caused by internal hernia or abdominal wall hernia, and this is what we're going to talk about one by one. Intussusception, there's different causes. But they all kind of fall under intestinal obstruction. Severe untreatable reflux, okay? Leaks, intra-abdominal infection, bleeding after surgery, blood clots, and then nutritional complications, okay? So, a little bit of what I mentioned in the beginning. Our experience is that we truly do have very low complication rates compared with national averages. Overall complication rate, readmission, reoperation rates nationally are about 4.6%. We're about 1.3% overall. So your best chance at not having one of these complications is to come to one of these high volume centers of excellence like ours. And we often get patients that get shipped in from other hospitals, from other states, even Oklahoma or Nebraska, and they've had surgery either recently or sometimes 20 plus years ago. So because we are a center of reference, we've been able to see some stuff that is very unique, that is very rare, but also sometimes very advanced complications, and that's given us more experience to be able to treat the more common complications better. And so what I can assure you is, I can't assure you that you're not going to have a complication, and like I said, our rate is not 0%, but we will know how to diagnose and treat it should they arise, and we can fix it. And what I tell patients most of all, what you should know is we're never going to leave you alone. We're never going to ship you out to some other hospital, and we're just not going to let you get worse. So what I tell patients all the time is just call. Just call. We're available. We'll get back to you. And sometimes maybe it's just a reassuring phone call, but sometimes, that phone call is going to prompt us to tell you, you need to come in and be seen right away, or you need to come to your local ER and then get transferred in because this sounds serious. So we just never want you to feel like we're not going to be there for you. Okay, so let's talk about ulcers. These are almost exclusive to gastric bypass. Okay, and if you remember how the gastric bypass is built, there's a small pouch, and then there's intestine connected to there, and that area is very vulnerable because the stomach and the intestine have separate blood supplies. When they are joined surgically, they eventually fuse together, but at that margin, the blood vessels aren't quite as good as they are in the native tissue. Okay, so that area is always susceptible to it's just more vulnerable. That's why when patients smoke after gastric bypass, it's almost guaranteed that they'll develop an ulcer. The tobacco shuts down the small blood vessels, and then that area, which is already sensitive and vulnerable, gets even less blood flow, less oxygen, and the cells die, and then you develop an ulcer. An ulcer is basically like a little crater that forms in the lining of the intestine. And as the crater gets deeper, it erodes into the nerves. Once it erodes into the nerves, then the primary symptom of these is usually severe epigastric pain, right up here, right under the breastbone, nausea. I tell people, think of an ulcer as a really bad skinned knee. And every time you put your pants on or rub it, it's like, ow, So anytime food passes there, anytime you swallow saliva, it irritates that ulcer and you feel it. And it's horrible. It's pain, nausea, the sliming, which is that foamy stuff that comes up, okay? And so these patients, they say, I'm spitting up this white stuff, I'm nauseous, I'm hurting all the time, I don't want to eat, I can't drink anything. Smoking is the number one cause, followed by the use of anti-inflammatory medications, especially the strong ones on a daily basis, like Advil, aspirin, Aleve, naproxen. Those groups of medications can really hurt that vulnerable intestine. And then prolonged steroid use, such as prednisone, there's always a risk with that. So some of those patients that have to be on long-term prednisone, we will typically treat with an acid-reducing medication or Carafate, which is a coating medication to protect that vulnerable intestine. Ulcers are generally diagnosed clinically, which means if you tell us those symptoms, they're pretty suspicious. We'll pretty much know that that's an ulcer, but we always want to confirm with an endoscopy. Generally, when patients come and we think they have an ulcer, we put them on treatment immediately and then schedule them for an endoscopy as soon as they're available so that we can get a diagnosis of what it looks like, how big it is, and then these will heal in 4 to 6 weeks, the vast majority. If someone is smoking, what we tell them is it will never heal unless you stop smoking. You're going to be on medication forever, or the ulcer is going to get worse. If that crater starts eroding not just into the nerves but into the blood vessel, guess what happens? You get bleeding ulcers and you're vomiting blood or having black stools, and then you get anemic. If that ulcer erodes all the way through the lining of the intestine, guess what happens? You perforate, okay? And then now you're spilling stuff into your abdominal cavity, peritonitis, and emergency surgery. So those are the complicated cases, right? The perforations, the bleeding, but the vast majority will heal in 4 to 6 weeks if the offending agent is taken away and the patient takes omeprazole and Carafate with good compliance for 4 to 6 weeks. They will heal. We don't regularly schedule an endoscopy at 6 weeks just to make sure it's gone. Usually if patients' symptoms are better and they've improved, then we'll just tell them to complete the treatment and that's it. If it's not getting better, that's when we'll do a second endoscopy to see what happened. And if the ulcer definitely shows that it is not getting better despite no smoking, no NSAIDs, no steroids, patient's doing everything right, we've tried one regimen, we've tried a second regimen. If it's not getting better and this patient is getting worse and worse with severe pain, sometimes they do have to go to a revisional surgery where we will go in and remove that ulcer tissue surgically and make a new, fresh connection. So it can require the revision of a bypass. See, this is what a gastric bypass should look like normally. This is the stomach tissue, which is the pouch, and then this is the intestinal tissue, which looks nice and pink and wavy like that. So this is a normal looking anastomosis, we call it, a stoma, pouch, intestine, okay? With an ulcer, that's what it'll look like, okay? So you can see the difference. You can see why these can hurt so much. This is the crater here, and it's being covered by this fibrinous tissue, okay? And it's very red and swollen, so it looks angry, it feels angry, and it is angry. And even these severe ulcers like that, as long as you coat the intestine, take the medication, they will heal. So, a stricture. A stricture is typically more common with gastric bypass. We have seen them with sleeves before. Number one risk factor for a stricture is typically a history of an ulcer in the past. Because if you remember this, sometimes this will heal completely, but it won't go back to looking like this. It'll leave a scar, and that scar will leave that hole too narrow, okay? Down to this size. You see that? Okay, remember this is the size that it's supposed to be, about the size of a quarter or so. That's how narrow it can get, pinpoint, smaller than a dime. So these patients have the sensation of food sticking. You eat, it feels like the food just lodges right there, it won't go through. You get a watery mouth, and then the food comes up undigested. Okay, it's just regurgitation right back up. Or the secretions, the saliva that you swallow throughout the day, eventually builds up, and then you also have that slimy, foamy stuff coming back. All right, and it hurts. It hurts when food goes down. So the treatment for this is we diagnose it with an endoscopy. Once again, the symptoms are very suspicious. We put a balloon down there through a guide wire. We put a guide wire through that little hole and then inflate the balloon up with air, and that balloon stretches it back to a bigger size, okay? So it went from that to that, and then patients can swallow better. But it usually requires 2 or 3 of these. So we'll do a dilation. We'll call the patient back in 2 weeks to do a second one, and sometimes even a third one until we get it back to its size, because the body wants to scar it down again, okay? So the majority will resolve in 2 or 3 dilations, but if a patient is very dehydrated, not able to eat, malnourished, then in addition to doing all this, we typically might bring them in for a few days to the hospital to get them renourished, rehydrated. And in very complicated cases where the stricture is just not opening or they're requiring dilation after dilation, sometimes that tissue just needs to be removed and a fresh new connection done as a revision, okay? So we have done that in the past. Thankfully, that's a very rare situation. The vast majority will resolve with a dilation, okay? How about the intestinal obstructions? Once again, because the bypass requires rerouting of the intestine and we're reconnecting things, that always leaves the potential for a complication with the intestinal part of the operation. So the sleeve doesn't really touch the intestines, there's no rerouting, and so we won't typically see intestinal obstructions with sleeve patients. This is more unique to gastric bypass. And they can be caused by something known as an internal hernia, adhesions or scar tissue, intussusception, or a ventral hernia. And I'll go over each one of those. The typical presenting symptoms: severe abdominal pain, vomiting, bloating because things are not moving through and it's building up, so the belly gets, looking like they're pregnant, no bowel movement, no gas. And most of these patients will end up in the ER because they can't take the pain. And so the ER doc will typically order a CAT scan, and then they call us because they will see on the CAT scan that there's a blockage. and they will typically tell us what it's from, and that decides whether that patient needs surgery right away or maybe we can wait. But yes, most will require that patient to come into the hospital because the pain is pretty severe and they're going to need some IV pain meds, and some of these will go on to surgery. So a ventral hernia is basically a hernia in the abdominal wall. That's kind of the garden variety hernia that we've all heard about, right? A bulging, a protrusion, so that can happen in the groin, but with this type of surgery, most patients will get a hernia at the site of a previous scar. And it happens there because even though that portion of the abdominal wall heals after surgery, it never heals quite as strong. And when there's pressure on it because of weight, then eventually that gives way, and then a little hole becomes a bigger hole, and usually fat herniates through there, but intestine can herniate through there. And if the intestine starts choking itself off, then that's what's called a strangulated hernia and could require emergency surgery. The funny thing is, the smaller the hernia defect, the more dangerous it is, right? Because if something herniates through there, it's like what do they call those? Finger traps, right? Where it goes in and you can't pull it out. So that's what happens with the intestine. Once it herniates, it starts accumulating gas, it starts getting swollen, and it starts getting bigger and bigger and bigger, and now it'll never get reduced through that hole, and then that becomes an emergency. The very big hernias, those are very bothersome to patients, but they're actually not that dangerous in terms of choking off your intestine because they're so big that most patients typically are able to push back whatever bulges out. And it'll bulge out when you cough, when you strain to go to the bathroom. If you lift something, you'll feel that bulge, and then usually patients will lay down on their back and kind of push it in, and then they feel it reduce back into the abdomen. And as long as they can do that, then it's not an emergency. But they become so uncomfortable that they should be fixed, okay? And these will generally be fixed with a surgery. Most of the times it's same-day surgery, and then we will put a little mesh in there and close that hole so that nothing comes out again. It's like a reinforcing material that plugs that hole. What about an internal hernia? An internal hernia is the same concept, but it doesn't happen in the abdominal wall. You can't feel it. There's no bulge. This happens deep on the inside. And this happens because in the gastric bypass, when we divide the intestine, we also divide the mesentery, this yellow sheet of fatty tissue that carries the blood vessels through the intestine. When we divide and make all our connections, we always close that with stitches so that this doesn't happen. However, think about it. We're stitching basically a layer of fat to another layer of fat. And what happens when you lose 150 pounds? You lose all that fat on the inside. So where we had closed the gap, a new gap forms because the fat vanishes. And so these can happen in patients who have had very significant weight loss. And a year after surgery, they will present with very severe abdominal pain about a half hour after they eat, really, really severe. The very classic symptom is that they have to bend over in a fetal position and hold their belly like this and bring their knees up or squat down. And when they do that, after some time, they get some relief because I think it kind of pushes things back. But this can be happening, I've seen patients be suffering this for a month or 2 months, just thinking that it was indigestion, and all the time they had this chronic internal hernia that was herniating, causing pain, and then reducing and resolving. Well, when we detect that this is going on, we will schedule that patient, after doing the studies, we'll schedule typically that patient for surgery because we want to fix this when it's not acutely twisted. Because what we want to avoid is the catastrophe of having intestine herniate, cut its blood supply off, and then you lose a bunch of intestine and it has to be removed. Because we have become very adept at picking this up early on, when we find this, we're able to do it electively as just a diagnostic laparoscopy with the little incisions. Otherwise, when somebody comes into the ER and they're acutely herniated like this and they're in a lot of pain, we'll typically have to open them up. That would require an open surgery because we got to get in there quickly, untwist things, and then what we do is just close these gaps again with, a special non-absorbable stitch so it doesn't happen again. So this can happen. Thankfully, the rate of this is less than 3%. I mean, it's pretty rare, but it can happen, okay? What about intussusception? Intussusception is probably even more rare than internal hernia, but what happens in these connections is that the intestine, instead of being nice and cylindrical like this, it starts telescoping into itself, okay? The intestine constantly contracts, okay, because it wants to move things along. What can happen at one of these lower connections is that in doing one of those contractions, it actually starts like engulfing itself, okay? I'll show you a picture of what that looks like. See? The intestine is actually like almost like sucking itself in. And what happens is if enough intestine gets intussuscepted, that'll cause a blockage. Severe pain, very similar symptoms, but this will show up very readily on a CAT scan, and then we'll have to go in and reduce that. We typically don't have to remove this intestine. You just pull it right back out, and then it reduces, and then you can put a couple of stitches to prevent it from doing that again. But this will typically go on to surgery, okay? So those are the intestinal obstructions. What about severe reflux? Now this one is pretty unique to sleeve. This can happen in sleeve patients, and it can be as high as 3, as high as 5% of the time. Okay, this is one of those issues that we are seeing with the sleeve, and the reason why it happens with the sleeve is because a gastric bypass, if you think about it, it's an emptying procedure. This pouch, there is no valve here, right? It readily empties down here into the intestine, and so you don't have acid coming up. This disconnected stomach that produces acid, the acid has no way to get from here to here. So gastric bypass is a surgery that is curative for severe reflux. But when the reflux is going on, for quite some time, what can be a problem is that the sleeve may have narrowed, okay? Instead of being like a nice cylinder, it may be too narrow. It may look like an hourglass, and then things are not emptying through. Plus, with a sleeve, the reason why we see more reflux, it's not drawn on here, but there's a valve here, okay, called the pylorus, and that allows food to empty at a gradual rate into the intestine. But because a sleeve is a narrow cylinder, this valve can tend to create a backflow, like a high-pressure system, and so food has a harder time emptying, and then you can get reflux. What can also happen is that patients develop a hiatal hernia. This is the diaphragm. So this is looking at somebody, chest here, and the diaphragm separates our chest from our abdomen, and the stomach, this stomach is drawn here as a normal stomach, not a sleeve, but imagine just the sleeve from here to here, right? And what can happen is, as patients lose weight and lose fat, this little defect right here in the diaphragm, it's normal. It's called the hiatus. It's what allows the esophagus to come from the chest into the abdomen. That can widen, and then the stomach or the top of the sleeve herniates up into the chest, and that's known as a hiatal hernia. Many patients will already have a hiatal hernia when they have their initial bariatric procedure, and if we find it, we fix it, okay? But some patients can develop it after surgery. And if they do with a sleeve, now when you eat food, it stays kind of trapped up here and it has a hard time passing through the rest of the sleeve, plus you have the valve down here. So these patients can end up with a tremendous amount of reflux. So it can be caused by abnormal scarring of the sleeve, a hiatal hernia, a narrowing of the sleeve, a sharp angle. And the typical symptom is just severe reflux, right? At night, it's this chest pain and like the sensation of acid washing up, hoarseness, cough, asthma, and they're taking omeprazole, they're taking Carafate, and it just won't go away because it's not something that the medication is going to be able to resolve. It's more of a mechanical issue that will eventually end up typically requiring a conversion to gastric bypass when this is becoming so severe. So we diagnose it with an endoscopy, we treat it with medications, but sometimes these, if they're truly intractable and they're not improving, they will end up needing a conversion to a gastric bypass. And what we would then do if there's a narrowing here, we just divide the stomach above the narrowing and create a pouch, and then just connect the intestine to that pouch, just like a gastric bypass. And that works very well. Those patients get complete relief of their symptoms right after surgery. And if there is a hiatal hernia, we'll fix it, and as we convert it to a gastric bypass as well. Okay. All right. What about leaks, intra-abdominal infection? A leak can happen with a sleeve or a gastric bypass. Thankfully, we've seen very few of them, but they can happen maybe, we do 1,600 surgeries a year, and, we may see about 1, at the most 2 leaks a year out of all those patients. So it's rare, but we do see them. And when we have seen them, in general, we'll tend to see them more with a sleeve as opposed to a gastric bypass. It's basically a disruption of the staple line. Okay, this is kind of a very crude drawing, but just so you understand, when we make these surgeries, we're dividing the stomach with surgical staplers. Those keep the tissues together, and they're very well engineered, and they work very well. Eventually, after a few days and after that, that first week, your stomach, that tissue basically fuses as one. You don't need those staples in there for life. It's impractical. We don't go in there and get them out, but you're not relying on those staples for life. At this point, if you've had surgery, months or years ago, if you were to go in there and look, you couldn't see the staples. Now the stomach has kind of become one structure again. But if that staple line gives way before the stomach has had a chance to scar, then there'll be a hole there. And when you eat or swallow, it comes right out. And so you can get very sick from a leak, okay? If it's a more chronic, smaller leak, then you're going to have symptoms, but you're not going to be as sick. But you can definitely get full-blown peritonitis. If the leak is small, you won't get full peritonitis. You'll just get a collection of infection by that leak, known as an abscess, and then that has to be drained. So, one way to treat these is have the radiologist put a needle into that abscess and leave a little drain, and drain all that pus and treat with antibiotics, and just wait for the body to close that off. We've been successful with that way. But if somebody comes in with severe pain, left shoulder pain, fever, sweating, and they're very sick, they will typically require a emergency surgery to wash out that infection, and then to patch that hole. And we have ways of doing that using intestine, using other methods, but that will typically require an emergency surgery. So if somebody has a leak, they're definitely going to be in the hospital. This is not something that we manage over the phone at home. Okay, you'll be in the hospital, you'll be admitted, you'll have IVs, and you'll have a full workup, and you'll probably require a surgery or at least an interventional radiology procedure. So I put smoking up here because it is one of the highest risk factors for leaks is if you are smoking prior to surgery. Why? Because smoking, once again, affects the tiniest blood vessels, and as that tissue is working to join itself and form one structure again, it relies on very good blood supply and oxygen. That's what the tissues in our body need to heal. And if that is not provided because of smoking, then it's just going to take much longer to heal. And then if that patient all of a sudden advances the diet or eats something or that's a little too heavy or eats a little too much and vomits, when they vomit and that staple line is not yet sealed, it can tear and then they'll get a leak. So thankfully, very rare, but they can be very serious. And then bleeding and blood clots. These things can happen after surgery. As you know, we give our patients blood thinner injections for a week after surgery to prevent post-operative blood clots because there is a very well-known increased risk of blood clots in weight loss surgery patients. So we do our best to minimize that by giving everybody 7 days of the Lovenox shots, and that's why you have to do it. But some patients develop it nonetheless, and it'll typically happen in the leg. If patients aren't walking enough, if they're not drinking enough, the blood gets thicker because you're dehydrated, your blood is not flowing as well, and that stagnant thick blood will end up clotting, and you get that clot in the leg. And then if you move and tear some of that clot off, then it shoots up and goes into your lung, and that's what's called a pulmonary embolus, a PE. So blood clots can be serious, and these are some of the presenting symptoms. And most of these patients will end up coming to the hospital because of the symptoms, and that's where they get diagnosed with a blood clot. And then they'll typically be admitted and put on a blood thinner regimen, and they may have to be on blood thinners for 6 months afterwards, okay? How about post-operative bleeding? This is something that we will typically detect even before you go home. And so some of our patients have required blood transfusions because, when we're it's a fine line that we try to manage, right? We don't want you to get blood clots, so you get blood thinners even prior to your surgery. You get a shot of heparin the morning of surgery. And, sometimes that ends up making your blood too thin, and then you are at risk of bleeding. And because we're dividing tissue and some of those little staple lines can ooze, we never end a surgery seeing blood actively bleeding. Okay, that doesn't happen. But sometimes a blood vessel that wasn't showing itself, or a little bit of oozing later on that night, can start bleeding more. And so that's why you had that little drain after surgery. And sometimes we look at that drain and it's very red and it's putting out a lot. And so we know that patient is bleeding a little more, and we'll check blood work. And if the hemoglobin's going down and that patient gets dizzy when they get up, then they probably need a transfusion to replace some of that blood. So we've had to give some transfusions, but once again, it's a rare event. We've had people bleed even after they've gone home, like a late bleed. And so those are harder to treat because by the time the patient identifies that something's wrong, they've probably accumulated a pretty good amount of blood, and so they'll come in with an intra-abdominal hematoma. And the treatment for that, thankfully, the body eventually clots that off, and then we just wait for it to reabsorb over several days, actually. Not several days in the hospital, but, if they need a blood transfusion, we'll treat it that way, and then just kind of wait for the body to clot that off. We rarely, if ever, have had to take a patient back emergently to the OR because they're bleeding. Because usually, if you go in, you don't see this pumping vessel that's bleeding. It's never that. It's always just kind of diffuse oozing, so there's not much you can do surgically. So the bleeds that can happen, we'll typically manage them without surgery and just supporting with a blood transfusion of a unit or two. And then, after a day or so, we can tell that the bleeding has subsided, and then everything kind of goes back to normal. Okay, this is the last slide. This is just nutritional complications, and this can be a whole topic in and of itself, and so we're not going to go into every specific, vitamin A or copper deficiency or whatnot, but suffice it to say that it can happen with both surgeries. The number one cause of nutritional complications is noncompliance. So, unfortunately, that is somewhere where the patients truly have control of this happening or not. If you're getting enough protein, enough water, and you're taking your supplements, you're not going to run into this. If you're not, you're putting yourself at risk. Now, there are some patients where they're doing the right thing, but they can't because something else is wrong. For example, if you have a stricture and nothing goes down that you swallow, you'll definitely run into this. So sometimes they're trying to do the right thing, but they can't because it's a sign of something else going on. But vitamin deficiencies, anemia, electrolyte imbalances like low potassium, low magnesium because of not enough hydration, or protein malnutrition, if you're getting more hair loss than normal, if your nails are brittle and breaking, then that could be a sign that you're not getting enough protein or enough vitamin C. So regular compliance with supplements, long-term follow-up visits, support group attendance, and regular blood work. So this is interesting because you're all here, and those of you watching live, thank you for doing so. If you look at the guidelines of the ASMBS and the textbooks that talk about this, this is a major component of avoiding nutritional complications. And I was happy to read that because I said, well, isn't this nice? We're going to be talking at a support group about this. Encourage your friends and family members to come to these. I mean, they're helpful. They're helpful, And whether you're doing it at home on live stream or you're coming here, the topics are varied, and somewhere along the line you're going to hear something that maybe you forgot to do or stopped doing, and it can help you get back and being compliant, and it just helps to be accountable to another group of people. So encourage you to keep attending, and thank you for setting these up, Katie and Leslie as well for being here, and Amber as well. So we encourage you to continue coming, and thank you for doing so. All right, that's enough. I went over. I said I wasn't going to talk that much, but wanted to just kind of give a general picture of these complications, and now it's time for you to ask some questions. I'm going to back up just a little because I want to turn on this light. Okay. So fire away. If there was something that wasn't on here, please feel free to ask, or if you didn't understand something as well. We'll take all the time necessary to answer. Does anybody want to be vulnerable and tell us if they've had a complication? You don't have to, but if not, that's okay. All right.
I have a question.
Yes.
I had surgery 2 weeks ago, and I've kind of got some lumps underneath where my incisions are, and on a couple of them. Is that normal?
Okay, yeah, so I'm going to repeat your question so that the audience can hear. So the question was, you had surgery 2 weeks ago, and you're feeling some lumps under the incision, and is that normal? The answer is yes, that's very normal. What you're feeling is the scar tissue, and you're probably feeling it under the left-sided incision, where that's the big one. That's the one that hurts the most. In the sleeve, that's where we stretch that incision to pull out the stomach. In the bypass, we stretch that incision to put in the special stapler that's going to create the connection. And that left-sided incision always hurts more because we close it with a special stitch so that you don't get a hernia. And that stitch goes right through the muscle and the fascia, and we tie it down and it lumps everything together. So it hurts, feels like a really bad Charlie horse, and that scar tissue that you're feeling there feels like a lump. It doesn't mean it's a hernia.
Okay.
All right. Yes, in front here.
Can we talk about constipation?
Can we talk about constipation? Yes, yes we can, yeah.
My question is, Miralax doesn't work, magnesia isn't working.
Mm-hmm.
Is it okay at 3 weeks out for enemas or suppositories?
Yes.
Or the actual laxative?
Right. So the question is constipation, 3 weeks out from surgery, milk of magnesia is not working, Miralax is not working. Is it okay to try enemas or suppositories or a laxative? The answer is yes. There is a kind of stepwise management to postoperative constipation. If you think about it, it's the perfect storm for getting constipated, right? You go on a high-protein diet, which tends to cause constipation. You're not drinking as much, causes constipation. Opioid pain meds cause constipation. You're not walking around as much, causes constipation. You're not getting enough fiber. So it really is a perfect storm, and most patients postoperatively do have it. So the typical stepwise approach is to try Miralax first or milk and magnesia, but if that's not working, I always have my patients add a Dulcolax suppository, 10 milligrams daily until you have a bowel movement, because what ends up happening, especially after 3 weeks, is that you're going to have some really hard, small pellets of stool, okay, that are very painful to pass, and so your colon just won't work because it doesn't want to pass those. And suppository helps by relaxing, okay, the rectum and lubricating things so that those little hard pellets of stool come out, and then once those come out, then you'll start having regular bowel movements. An enema can also help with that. People ask me, should I take Colace? And I tell them, well, yes, you should. That's a stool softener, but it's not going to help you have a bowel movement. It's going to prevent you from getting constipated in the future. And if you struggle with constipation now, it may be a good idea to just add a 100 milligram Colace pill every day to prevent you from staying constipated. But right now, it's not going to do much to help you relieve the constipation acutely. For that, I would try suppositories next. in addition to continuing the Miralax. And if that doesn't work, then try an enema, like a Fleet's enema or a warm tap water enema. This too shall pass.
Stay away from fiber supplements.
Yeah, fiber supplements as well. Not a good choice. Fiber, when it gets on the inside and it mixes with water, swells up, and so that's going to make you feel very unpleasant. So try the other thing. Do we have a live question?
Yeah, some of it was answered, but they said, what if having dark stools or in constipation at 8 weeks post-op? So you pretty much covered the second part.
Yeah, I mean, if there's dark stools, so if they're taking iron supplements, that's a known side effect of iron supplements. Maybe they're not, but known side effect of iron supplements is to cause dark stools.
That would be for 8 weeks post-op, right?
What's that? Yeah, exactly. They should be taking iron. So that can be just the iron supplement. Right, because it's in the vitamin, but some patients are taking, in addition to the vitamin, they're taking like ferrous sulfate, and so that can definitely cause it. But it's also sometimes a concern for bleeding, right? If there's some bleeding happening up here, by the time the blood gets digested and mixed with acid, it can make the stools look like a tarry black. That's usually major bleeding, but if the stools are looking dark and they're not having regular bowel movements 2 months post-op, we have the 2-month visit for that purpose. So if they haven't come into the office, I'd advise you just make an appointment with us, with the nurse practitioner, and we'll look into that further. Anybody else? Any other Facebook questions? Yes.
I have this problem with feeling weak all the time.
You have a problem with feeling weak all the time?
Yeah.
Okay. So and you had your surgery a little bit ago. I know, because I did it.
3 weeks ago.
So 3 weeks ago. Okay. So weakness 3 weeks after surgery could have a lot of underlying causes. Okay. One of the first things I'd ask is, are you getting enough fluids? Because
I'm having trouble with fluids.
okay, so if you're having trouble with fluids, that's probably the cause. And what happens is sometimes when dehydration sets in, it's very hard to catch up to it just orally, because dehydration can cause nausea and just, a sensation of not feeling well. And so those patients just don't drink enough, and they get into this vicious cycle where the dehydration gets worse, they feel worse, they don't drink, the dehydration gets worse, and so it spirals until they're really miserable. So sometimes, within 3 weeks of surgery, if you're really not getting enough, if you're not peeing enough, if the urine is very dark and you feel weak, come into the office, and sometimes we can break that cycle by giving you a couple of bags of IV and maybe some nausea medication, and then figure out, is it because, are you not drinking because things are getting stuck? Are they hurting when you drink? So the other cause for weakness after surgery is sometimes patients are on blood pressure medication and they don't realize it, but the blood pressure has already come back down to normal, and the blood pressure medication is actually driving down their blood pressure to very low levels, and then they feel weak and just kind of lethargic, and so and then the blood pressure is like 90/60 or something, and say, okay, well, you don't need blood pressure medication, that's why you feel weak, and we take them off that blood pressure medication, it comes right back up to normal. What else? Not enough calorie intake, right? So
I can only eat an ounce of meat.
yeah, come into the office. Come to the office, we'll sit down, we'll look at what you're eating, what you're drinking, and if you need an IV, we'll help you with that. And so that's a great example of just staying in touch, and sometimes just breaking these cycles and getting you back to normal. Okay? Anybody else?
There was another Facebook question.
Uh-huh.
What about dark green stools?
Dark green stools, okay. So the stools turn green because of a component in our intestine called bile. Okay, bile has that green look, and it's actually what mixes with the stool and gives it its brown color. If we didn't have bile, the stools would look white, like clay colored. In fact, that's a known condition when patients have obstruction of their gallbladder or obstruction of the intestine and they're not getting bile flowing through, the stools turn white. So that's a sign of poor flow of bile. But if they're very green, that could be an infection. If that's associated with green stools with diarrhea, like having a lot of stools, that could be an infection. It could be that you'd have to see what the other symptoms are. I would say if the stools are normal consistency and they're having daily bowel movements and it's not hurting, it's not diarrhea, it's not constipation, it's just a different color, I probably wouldn't mind the color as much as, is it associated with pain, with obstruction, if there's other symptoms involved, then, sometimes that's an early diagnosis of like intussusception when it's that lower connection in the Roux-en-Y. If there's a blockage there, the bile won't flow and there can be changes in the stool color. But I would say for the most part that truly green stools are not normal. I mean, most people have brown, so it should be something to look into. And there's stool studies that can be done. And sometimes when it's a problem, an ongoing problem with stools, we'll refer patients to a gastroenterologist. That's one situation where maybe seeing a gastroenterologist having a colonoscopy might be helpful. So, any other questions in the back? Yes. Okay, I'm going to repeat your question. You had your gallbladder removed some time ago, and what's that?
Just in September.
Okay, in September, so a couple of months ago, and since then, you've been having a lot of issues with digestion, and I'm going to guess that's diarrhea, right? Or bloating,
It's kind of like
one or the other?
And I've dramatically changed my diet.
And you've changed your so diarrhea after gallbladder surgery is very well known and well established, okay? Because when you take out the gallbladder, you still have bile flowing into the intestine, but it goes in slower because the gallbladder is now gone and it can't squirt all that bile in. And so it's a well-known side effect of gallbladder surgery is to have diarrhea, loose stools, indigestion. If it becomes very uncomfortable, there is a medication specifically designed for post-gallbladder diarrhea. It's called Colestid. So your question then was, if you're going to have the weight loss surgery, is that going to add more problems to the ones that you're currently having? Well, I would say that that I don't think it's going to add more problems. If anything, the constipation that we generally see may throw you more into the normal. But we do plenty of patients that have had their gallbladder out go on to have weight loss surgery, and it doesn't make things worse. But it'd be interesting to look into. Maybe you respond to Colestid, maybe you got antibiotics for the surgery, and then that threw off your gut flora, right? I've seen that happen, and then things aren't the same. So, then I have those patients take a probiotic. You have no idea how many patients I've recommended a probiotic to, and once they start taking probiotic, they're like, man, a lot of those symptoms I was having went away once your intestine finds its balance. So that be recommended. But no, I don't think that having weight loss surgery is now going to really make you miserable. I think for the vast majority of patients, when they have issues after a gallbladder surgery, it's temporary. And it can be up to 2-3 months, and then things find their balance. A couple more. You first and then her.
Well, mine's kind of personal too. I'm 2 weeks out,
Uh-huh.
and I'm not having the issues with being able to eat or drink. I can do both.
Mm-hmm.
So that makes me think, either I'm one of the special people, and then they talk about the stretching of the pouch,
Uh-huh.
and sleep. So is that such a thing?
Okay, yes. That's a good question. Because, as I say, it's a good question because it gets asked a lot, and patients think that their surgery is not working because they're not throwing up. So, I'm glad you asked it because it's good to address it. Let me just be clear. The surgeries are not designed to work by making you feel horrible and throwing up and hurting. And I mean, it's almost like, I get it. I mean, it's almost like our minds are programmed. Like if I'm not suffering, like I'm only going to gain through pain. And, if I'm not suffering, it's not really working. This happens especially in band patients. So band patients were used to eating too much and throwing up. And then they go on to have one of these surgeries like the bypass, and now they can eat and things go through fine, and they're like, whoa, something's not working. And I tell them, actually, it's working great. So the fact that you can eat and drink and are not having issues, that's how it's designed to be. So I'm sure you're doing fine. 2 weeks is so early to gauge how things are going to work, and you may be even concerned that you're not losing weight, and then you're like, well, I don't feel anything, so something's not working. It's so early. So just give it some time and be happy that things are going just like they're supposed to.
I feel like I overdrink, and then I'm like, okay, have I drank too much now? And I can go on.
Well, to be honest, I mean, sometimes patients do overdrink, but it happens to most patients. You forget, and you're used to drinking so much, but one overdrink is not going to stretch out your sleeve or your pouch and ruin things. That doesn't happen.
Come back up.
That's right.
Okay.
It'll come back up much more readily than it's so resistant in there that the path of least resistance is this way. So, yes.
Okay, my surgery is actually tomorrow morning.
Oh, great. Surgery tomorrow morning. Congratulations. And you are here at support group. That's admirable.
But my question is, about a week and a half ago, I had a pretty severe allergic reaction and had to get a steroid shot.
Okay,
Is
yeah.
that going to have any sort of impact? I mean, I know it might affect, my immune system.
Yeah, it's not going to affect anything, actually. So the question, she's having surgery tomorrow and is here at support group learning about complications, and that's pretty brave. But she had a steroid shot for an allergic condition, and is that going to affect anything? So no, a week, 2 weeks before surgery, one steroid injection is not going to ruin anything. The steroids that concern us and worry us are when patients have been on prednisone for months, 10, 15, 20 milligrams, and they show up to surgery and they haven't been off the prednisone. That's definitely a risk for having suppressed immune system. So we work with those doctors to try to get them off and coordinate it really well so that your recovery has no issues with the steroids. And then once you've recovered, we can get you back on it if you need it. So.
Quick question, is there anything different a bariatric patient would need to do with having a colonoscopy?
Good question. So is there anything different that a bariatric patient needs to do with having a colonoscopy? The short answer is no, nothing different. But of course you have to drink the gallon of stuff, right? So you may need less. Remember, the goal with the gallon of stuff is never to drink the whole gallon. It's so that you start having clear bowel movements and no stool is coming out. Once you reach that point, you don't have to finish the rest of the gallon, at least as far as that's my opinion. I might have some gastroenterologist that's watching this live, I doubt it, tell me, no, they got to drink the whole thing. Because they like, and I'm the same way. It's like with the liquid. I want the instructions to apply to everybody the same way. Otherwise, you get all these deviations. But the goal is to just kind of clean you out. And once you reach that point, because you're limited in volume as to how much you can drink, you don't necessarily need to finish that entire gallon. But if you are still having some residual stool come through, then keep drinking. Just drink like you drink everything else, small volumes. Other than that, no special preparation. In the back, and then we'll take one more. In the back, and then we'll take one more there.
So, of all the complications you've talked about tonight, which ones are most prevalent after 6 months?
Yeah, great question. Of the ones that we talked about, the complications we talked about tonight, which ones are more prevalent after 6 months? Honestly, So the intestinal obstructions, that'll typically happen after 6 months or a year. Ulcers are pretty varied. Ulcers can happen early or they can happen later. They tend to happen later in somebody who picks up smoking. They tend to happen earlier as a result not of smoking, but as the tissues are healing and those staples, sometimes the staples can irritate and cause an ulcer. The bleeding and the blood clots, you're not going to see those after 6 months. Those are early complications. The nutritional stuff will typically happen after 6 months. Strictures as well. So hopefully that answers. I mean, there are certain, like leaks and stuff are not going to happen after 6 months. That's something that happens in the first week after surgery or so. Do you have another online question?
So I don't know how you're going to answer this, but what about depression? I've seen a lot of comments on an increase of depression after surgery.
Okay, so depression after surgery. So I wouldn't consider that a complication, but it's a known issue. I mean, some patients with all the changes that are happening, so I mean that might be a great topic to talk about in support group, because yeah, there can be a bump. I mean, we have seen patients get much better from their depression, once they get healthier, but certainly some patients have a harder time struggling with the changes. What else can happen? Friendships can break up because now you're different and successful, and sometimes, I mean, humans are weird, but that puts people off sometimes, and they're jealous or whatever. And then, I mean, this happens in marriages too. We know that sometimes there's a control relationship, and somebody that's very heavy with low self-esteem gets controlled by the other partner, and now they lose weight and are all empowered and positive, and that partner starts getting really jealous and can't control them, and then it's kind of a toxic relationship. So that's kind of getting into territory that would be great for another support group. But body image issues, we know, we've all heard and know that it's a thing, that sometimes patients see the big person in the mirror, not the thinner, healthier person that they are now, and they struggle with that. My answer to that would be, if there is depression, if there is issues, once again, stay in touch with your program here. We have 2 great psychologists that are there specifically for that, to help cope with all the changes and with issues afterwards. Maybe there was a change in medication. So there can be a lot of different causes, but if you stay close and you use the resources available, it's something very treatable and hopefully just very temporary.
Okay, so medications, I take the Calorie 4 times a day. On top of these calcium citrate, the vitamins, that's, different times of the day, plus I have other medications.
Right.
It gets real confusing.
Yeah, it does.
About the Calorie. When can I take that? When I know I'm supposed to take it before I eat, 30 minutes before I eat. But then with the other meds.
So this is the way, and this is probably something that you can discuss with your provider more in the office. But the medications can get really tedious. And with Carafate, because it can affect absorption, they'll tell you don't take anything before. So now, I mean, you've got alarms going off every 30 minutes. Now take this, now take this. And what happens is sometimes people, they give up. There's like, this is too much, I just won't take anything. So this is what I tell patients, and this is not, in the case of Carafate, it's kind of a unique situation, because they're giving you the Carafate for some reason. Maybe you're having issues with nausea or whatnot. I would say that that's a priority right now. Take your Carafate until whatever symptoms you're having get better, and then you won't need the Carafate eventually. But if it's causing so much interruption, focus on getting the Carafate and then at least doing your vitamins. Calcium, you'll probably be okay. You'll probably be okay for a couple of weeks if you don't take calcium, but take your vitamin. And what I tell patients, when the medications get so tedious and the vitamins, I say, figure out something that works and that you will commit to sticking to. I've had people give up on the vitamins and the calcium because it just interferes so much with their day. And I tell them, well, can you take at least 1 and 1 in the morning? Yeah, I can do that. I can remember, I can set it out, and I can take it in the morning. Okay, at least taking 1 and 1 in the morning is better than taking nothing and nothing. So, start with small steps, and then maybe you'll get compliant with the morning doses, and then you can, commit to taking the evening dose or whatever. But, stick to something that you can commit to. In your specific case, I would say focus on the Carafate and whatever other medications you do need to take, and at least 1 vitamin a day for now, and then slowly, add the calcium and stuff in once you're off the Carafate. All right. Okay, well, thank you so much. You had great questions, and thank you for being here.